We are in week number 3 of our rural onboarding program. And this week we are specifically focusing on women's health, and tomorrow we'll send out the resource pack as well with the updated links and tools for maternal health as well as reproductive health care. Just a little heads up in terms of next week, we are looking at angioedema. We might move the child health talk to the last week just to wait for our hubbub to die down in terms of our speaker. And so I might be swapping out and doing that session in week 5, but we will keep you guys posted. So for tonight's rural onboarding, we are very pleased to have Prof Justus Hofmeyr with us, and Prof is very much part of our Rudasa onboarding, I think, from the very beginning, and we've got you will see on the list of webinars that's already on our YouTube channel. There are several there that are worthwhile also referring back to, specifically around safe care, for example, during cesarean section, etc. So very worthwhile to look out for. Tonight is going to look at evidence-based respectful care during labor and postpartum. And currently he is working through the University of Botswana and with the Effective Care Research Unit, South Africa. So Prof Hofmeyr is the Associate Director of the Effective Care Research Unit of South Africa, and his research interests are innovations relevant to maternal health in low resource settings, with over 400 plus peer-reviewed publications. So he's conceived several obstetric innovations: titrated oral misoprostol solution for labor induction, delayed cord clamping to reduce preterm intra-ventricular haemorrhage, posterior axilla sling traction for shoulder dystocia, suction tube uterine tamponade, side-by-side Foley balloons for labor induction, and the reusable Maternawell tray for monitoring blood loss after birth. Some of these are covered in some of the other webinars that we have on the Rudasa YouTube channel, so do look out for those. And I'm sure he'll give you some tips on where to go and find more information on some of these innovations that are saving lives daily. So I'm going to stop my share here, and I would like to hand over to Prof Hofmeyr.
Thank you so much, Madeleine. I'm just going to share. There we are. So good evening, everyone, and thank you very much for this opportunity to speak to so many people at the same time. I'd like to acknowledge people who've worked with me on what I'm going to be presenting, particularly Mandisa Singata Madlike, who works with me in the Effective Care Research Unit, and I've no financial conflicts of interest to declare. I just try and see the... Sometimes there we are. So I'm going to go fairly quickly this evening because I'd love to have time to discuss at the end. So if there's something that's not clear, please make a note and we can discuss it at the end. I'm not going to talk about anything that requires fancy equipment or high level of expertise. I'm going to talk about the very common basic things that are so difficult to do. You know, the fancy things are easy, but the basic things are the most difficult. And I'll talk quickly about improving outcomes, labor induction, labor care, third stage care, monitoring blood loss, postpartum and refractory postpartum hemorrhage. And if there's time, I'll go on to postpartum contraception and on-site midwife obstetric units. First of all, we all want to improve outcomes where we are working. That's really what we want to do. And outcomes don't improve by magic or by wishful thinking. We will only improve outcomes when we change the way we do things to a better way. And change is extremely difficult. It takes an actual decision that we're going to change the way we do things and a formal program in place to make sure that we do these changes, which involves training of our staff, having champions to support the change, and having mentorship and ongoing input to make those changes work. So I'm going to start at the beginning of labor. How can we make labor induction safer? In the 1990s, we really had a nightmare of uterine ruptures due to off-label use of misoprostol, particularly when used vaginally. And we came up with a very simple method of using oral misoprostol, where we simply put a tablet into 200 ml of tap water, label it clearly, and discard it after 24 hours, and then measure out 25 ml to give orally every 2 hours, which we found to be a safe dose for inducing labor. And this is used, in fact, it's recommended by WHO and used all over the world now. But more recently, we've realized that, in fact, the old-fashioned Foley balloon is by far the safest method of labor induction. There's much less risk of uterine hyperstimulation than with either prostaglandins like misoprostol or oxytocin. And it's particularly important where we work, where we often don't have very intensive fetal monitoring, to try and avoid misoprostol and oxytocin, and we should all be using the Foley balloon as our primary method of labor induction. The one limitation is that the balloon may fall out before labor has been established. And when this happens, we've recently, or in fact for some years now, been using 3 Foley balloons side by side. What we do is, on a sterile surface, lay out the 3 balloons and tape them very symmetrically, because you want all 3 of those balloons to be exactly at the same level. If one's higher than the other, then the lower one's going to just pull through. So you need to tape them securely and symmetrically, pass them all through the cervix, inflate each with 60 or more mils of fluid, and apply light traction, about 200 mils of water, either a bag of water or just a bottle, a drinking bottle with 200 mils of water. One of our residents in Botswana did her MA thesis on a study where she did a proof of concept trial with side-by-side Foley balloons. And in that study, 60% of the women induced with the 3 Foley side-by-side went on to deliver spontaneously vaginally without any need for oxytocin or misoprostol. And then to move on to the care we give during labor. And I think a very important event was 2018, when WHO completely revised their guidelines on intrapartum care and introduced the concept of intrapartum care for a positive birth experience. And this meant evidence-based, respectful care. And that's the most difficult part of it. As part of this process, WHO conducted a big study in Nigeria and Uganda. 5,500 births, normal births, were plotted on a partogram. And what they found, and these were all patients who had spontaneous onset of labor and went on to deliver a healthy baby spontaneously with no complications. And the average rate of cervical dilatation is what we all know it should be, 1 centimeter per hour. But when they looked at the individual rates of individual women, they were all over the place. So some went from 4 to 10 centimeters in less than an hour, and others took more than 24 hours, but they all ended up with a healthy birth, with a healthy, normal delivery of a healthy baby. So this 1 centimeter an hour is an average, but it really is not that helpful in individual women, because we know women are so variable in the way that they progress labor. And so we need to change our approach, not expecting everybody to follow that 1 centimeter an hour rule, but rather to assess women more holistically. Is the mother well? Is the baby well? Is the labor still progressing? Are there no signs of CPD? And try and make a more holistic decision about whether we need to intervene, or whether it's just a healthy woman with a healthy labor that happens to be going slower than other women. So as part of this process, the WHO developed this labor care guide to replace the partograph, which was developed in Zimbabwe in 1972. I want to emphasize that this is not yet implemented in South Africa. I hope it will be, but I do think we all need to know about this partograph. The important aspects are that it is an active phase partograph that monitors only from 5 centimeters to full dilatation. And most importantly, it's got a section for monitoring the second stage of labor, which is a big gap in the old partograph. So it has a time scale like the old partograph. It has an alert column, which sets out what we would expect a healthy woman to be, the recordings in a healthy woman to be. And then it has that second stage section. So it's not supposed to be simply a document which we fill out to document what happened in labor. It's a monitoring to action tool where we fill out what happens in labor. So first of all, we assess all these parameters. We record them at the time that they happened. Then we compare what we find with our reference column. And if what we find is not consistent with what we expect to be in the reference column, we then have to make a plan together with the woman about what we need to do now to correct these problematic recordings that we've made. The most important section, I think, of the new partograph is that second section, which is called supportive care, and where we actually record the 4 key aspects of respectful care, which are women having a companion, being offered adequate pain relief, being offered oral fluid, plenty of oral fluid, and avoiding the supine position. And that's what I'm going to focus on for a while now. Now, why are childbirth companions so important? I'm taking you right back to the childbirth companion study we did at Coronation Hospital in the late 1980s, where we recruited from the local community volunteer childbirth companions, which they were older women with no medical training who said they wanted to give something back to their community, and they came into the hospital as volunteer companions. And then we did a classical randomized trial, women having their first baby with no companion, with no complications, but were asked to sign consent. If they did, they were randomly allocated to a control group with no companion, or an intervention group who had one of the volunteer companions who was just asked to stay with them during labor and provide comfort, reassurance, and praise throughout the labor. That was the only intervention. We followed the mothers up after birth and up to 12 months. And the outcomes were absolutely surprising, even to us, in that compared with the control group, the women who were randomly allocated to have a companion had significantly more positive labor experience. They were more successful at breastfeeding their babies, which is a life-saving thing for babies. They had better self-esteem. They had better confidence in their ability to be a mother. More of them actually brought their child with them to the 6-week visit rather than leaving the child with someone else at home. And they had significantly less depression, which is a major problem linked to poor childhood development. So we concluded that labor and birth in a positive, supportive environment can be a very empowering experience for women. And it's where women develop the self-esteem and confidence in their strength and ability to breastfeed and care for their babies. It protects them from developing postpartum depression, and this may well translate to improved childhood health and development. Now, since in many other trials, and these are all randomized trials of childbirth companions have been done, and they show absolutely clearly that continuous support in childbirth is associated with a 25% reduction in cesarean birth, 31% reduction in women having a bad experience, a 38% reduction in low APGAR scores, and there's really no other intervention we know of in labor which has such a profound effect, not only in terms of personal benefits, but improved hard outcomes of labor. And nothing should get in the way of offering companions of choice. And I say this because whenever I give these data, I have the comments, yes, but we haven't got space, we haven't got privacy, we haven't got this, we haven't got that. The point is that labor companionship is so absolutely critical that wherever we are, whatever our situation, we have to find a way of ensuring that our patients have what is their right. When you think of someone giving birth, it's their right to have a family member with them, whoever they want. If they want their mother, or they want their partner, or they want their sister or their friend, it's an absolute right that they have, and we have to find a way to make that available to them. And then quickly, why is it's so important to avoid the supine position? Now, the problem with the supine position is that most women are fine in the supine position, so we get a false sense of security. And we've been using supine positions for birth for generations, and most babies are fine. But there's a small proportion of women who develop compression of the aorta and or the inferior vena cava, which can cause the mother to be hypertensive and weak, and the baby to have severe placental insufficiency. And we don't know which woman is going to have supine hypertension. And so we have to avoid the supine position for everyone, particularly in the second stage of labor. This is a patient in labor in the supine position where the fetal heart drops to unrecordable, and only when she turns on her side does it recover. Another woman where she was on her side for several minutes, and again, the fetal heart was off the scale below 50 for several minutes before she was turned on her side, and it recovers. And you can just imagine what this degree of hypoxia does to the baby. And this is a 15-year-old mother whose baby was in good condition until the second stage. In second stage, she was supine. She complained that she was feeling weak. She couldn't push. We thought this was a good or a reasonable tracing in second stage. But eventually when she delivered, and here you can see these are all her pushing efforts, this is the point at which the baby is born. And at that moment, we saw this heart rate dropped from about 200 down to below 100. We realized that this was the mother had a massive tachycardia because of supine hypertension. And as soon as the uterus was empty, it disappeared, but the baby by this time was dead due to supine hypertension. So it's a very, very serious condition. And again, it should be non-negotiable. No woman should be in the supine position in the second stage of labor. How should we avoid this? Of course, any other position is fine. Crouching, kneeling, upright. But we find the simplest position that our midwives find the easiest to do is a complete left lateral position with the thighs well flexed, one knee touching the mattress, the other knee pointing towards the ceiling. And the perineum is much more accessible. It's actually much easier to conduct the delivery in this position than in the supine position. But change is not easy. Whenever our textbooks all illustrate the mechanisms of labor in the supine position, and doctors and midwives have decades of good experience. So adjusting to a lateral or other position really takes an effort of will, and I want to tell you it takes months and months and months of trying to change that. But we have to change based on the knowledge that every now and then we'll avoid a catastrophe. Now, we know that checklists save lives. We know pilots kill far fewer people than doctors do, and pilots use very, very stringent checklists. In fact, we learned from pilots about checklists. We've got good evidence that surgical checklists save lives. And so for implementing this WHO approach to evidence-based patient-centered care in labor, we use the mnemonic COPE. C for companions, O for oral fluids, P for pain relief, E for eliminate the supine position. And if you just remember the word COPE, every time you see a patient in labor, check, go through your mind. Have we called a companion? Has she got oral fluids there at the bedside? It's no good having a tap that she can't reach. She must have fluids at the bedside, be encouraged to drink them. Have we offered her pain relief? And have we avoided the supine position? So the way we implemented this in Gaborone at the Princess Marina Hospital is we ran a project called the BOL Project, Better Outcomes with the WHO Labour Care Guide. We had patient information posters in the antenatal clinic, and we tried to encourage our staff to discuss childbirth companions at the antenatal clinic so they could make an arrangement for someone to be available. We trained all our labour ward staff, and we had posters up in the labour ward. So this was the poster in our antenatal clinic informing our patients that they're welcome to bring a companion of their choice when they're in labour. And this is the posters we had up in every single labour ward to remind our staff about the COPE intervention: companionship, oral fluids, pain relief, and eliminating the supine position. Now, did this work? Now, what I would like to say is I've been trying to implement these things in many hospitals for about 40 years, and basically I've been pretty unsuccessful. But doing this as a formal program with formal training and formal follow-up wasn't easy. It didn't happen quickly. It took months and months and months and months of mentorship and training. But in the end, it did work. So, wait, sorry. I think I've gone too far. No, I haven't. Let's go forward. So what we have here is a follow-up. We did postpartum questionnaires, first of all here, early on. It was just in the second month of the intervention before it was really working. And then we repeated it 2 years after working on this for 2 years. And we asked the woman, how did you feel about the experience of labor and birth? Initially, almost 60% said it was very bad. After 2 years, only 6% said it was very bad. Did you feel you had enough water or other fluid to drink? Initially, about half of them said they had enough. And follow-up, 3/4 said they had enough. Not perfect, but much better. Did you feel you had enough treatment for pain? Initially, only 1 in 5 felt they had enough treatment for pain. On follow-up, 50% felt they had enough treatment for pain. Did you have a companionship with you during labor? Early in the project, only 7% had a companion. After 2 years, almost 2/3 had a companion. What position were you in during the pushing part? Early on, about half of them said they were only flat on their back all the time. After 2 years, only 5% said they were only flat on their back. And how did you feel about the care you received? Initially, about 11% said they were not satisfied. In the follow-up, only 1 in 100 patients said they were not satisfied with the care. Now, I hope that this will convince people that it's really worth putting effort into programs like this, because in the end, our patients have a much, much better experience, and we know that their outcomes will be better. Let me find this. Okay, let's move from labor to postpartum care. And I'm going to talk briefly about the emotive intervention. I know many of you know about it, and then also evidence-based third-stage care. So very quickly, the emotive is a bundled approach to treatment of postpartum hemorrhage, which is based on E for early diagnosis, which means routine measurement of blood loss. If the measured blood loss is 500 mils or there are any signs of PPH, we quickly give them the whole bundle, not try this, try that. We give them massage, oxytocin, tranexamic acid, intravenous fluids, examination, escalation, call senior people in, if necessary, refer. But all of these things can be initiated by the midwife immediately because speed is of the essence. Now, to implement this emotive intervention, we need to have blood loss monitor devices. We need to have a PPH box with all the consumables we need. We need wall posters reminding the staff, hands-on training. We need to have a local midwife and doctor who act as champions. We need to monitor feedback and mentor, support the intervention, just like the labor care intervention. What we did in the emotive study, it was a cluster randomized trial, 80 hospitals, 14 of them in South Africa. We collected baseline data for 7 months, then randomly allocated 40 hospitals to be intervention and 40 to be control sites, and then 7 months of post-intervention data. And we compared post-intervention, the intervention sites with the control sites. And what our primary outcome was severe postpartum hemorrhage, in other words, 1,000 mils of blood loss, or laparotomy or death. In our control sites of 50,000 births, there were about 2,100 or 4.3% with severe PPH or laparotomy or death. In the intervention site, it was less than 800, 1.6%. So there was a 60% reduction. Maternal deaths, they were actually too few for statistical comparison, but there were 28 in the control sites and 17 in the intervention sites, suggesting that this reduction in severe PPH does translate to a reduction in maternal death. So this is really very important evidence and reason why we should all be using the emotive approach. And it's already been included into our ESMO algorithm for prevention and treatment of postpartum hemorrhage. One of the difficult problems is how should we monitor blood loss? In the emotive study, we used a brass V calibrated drape, which it's a standard method. It's very convenient because it's disposable. You could just bundle it up and throw it away. Low-cost drapes are being produced in South Africa by Sinapi and elsewhere by local manufacturers, but the limitations are the disposability. It's so difficult in our hospitals with the best intentions to keep a supply of disposables coming through. And of course, disposables in the long run are very costly. And another thing is that because our patients deliver on soft mattresses, they're indented and the blood tends to accumulate around the patient, so it has to be swept manually into the funnel. So because of these, we've developed the reusable Maternawell tray. Of course, it's 160 times less environmentally damaging than using disposable drapes. It's easy to place. The blood falls directly, the ramp or the wedge that you can see goes right under the patient. So the blood falls directly into the first well, which holds 500 mils. And if that overflows to the second well, that indicates postpartum hemorrhage. And because it's a long-term reusable item, it's about 60 times less expensive than drapes. So this just shows the Maternawell tray placed under the mother with blood falling directly into the first well. If the mother's in lithotomy, then the tray can be tucked underneath the mattress, and again, any blood can fall into the first well. A small randomized trial was done by Jade Esau as her MEd project in the Western Cape, and she compared patients who were allocated to receive the drape with those who had the tray. And she asked both the midwives and the mothers, would they be keen to use either the drape or the tray for future births. And most of the midwives and most of the mothers said yes, they would be keen. So both the drape and the tray were very acceptable to our midwives and to our mothers. If we do use the trays, they can be disinfected by a high-level disinfectant such as biocide. One could just use one of those bassinets or get a cheap plastic bin to soak the trays in and then dry them on a rack, or they can be autoclaved at 120 degrees. So our approach to third stage care needs to be evidence-based. And we recently reviewed all the evidence on what we use in third stage care, and we found there was good evidence for routine use of uterotonics like oxytocin, good evidence for early skin-to-skin contact, for delayed cord clamping, which is very important. It reduces the risk of childhood anemia, which is a major problem in children. Controlled cord traction, the evidence isn't as strong, and it's really only restricted to settings where people have been properly trained in its use. Delayed cord traction, I've said, is important to reduce childhood anemia, but for preterm babies, it's absolutely crucial. And this is a problem because it's totally counterintuitive. We all know when a preterm baby is born, all our instincts are to grab that baby, wrap it up, and run to the resuscitation area to resuscitate it. And this is the absolutely worst thing that we can do. And it was maybe 30 years ago, we first introduced the hypothesis that early clamping of the cord in preterm babies causes, and you'll see that picture there, we actually measured blood pressure in the umbilical arteries of newly born babies and showed that when the cord is clamped, you get a sudden surge in blood pressure, which in those delicate vessels in the periventricular area can cause hemorrhage and periventricular hemorrhage. And a recent systematic review of many, many randomized trials conducted all over the world showed that not only does delayed cord clamping in preterm babies reduce intraventricular hemorrhages, it reduces neonatal mortality by about 50%. This is a massive reduction, more than any other intervention we know of, including steroids and CPAP and all the other wonderful interventions we have. So for preterm births, again, delayed cord clamping is non-negotiable. It reduces mortality. We have to find ways of setting up our labor wards so that when the baby is born preterm, our initial care of that baby, keeping it warm, wrapping it up, drying it, checking for breathing, if necessary, doing chest compressions, is done at the bedside or on the table in theatre for at least a minute, but ideally for 2 minutes. If we can do that, we will reduce our mortality of preterm babies. We have to find strategies to make this work. As I say, it doesn't need fancy equipment, but it's something we have to take a decision. We are not going to allow preterm babies to be subjected to early cord clamping. So to implement this sort of evidence-based approach to third stage care, we've introduced another mnemonic for our checklist, and we use the mnemonic BOND. So BOND stands for baby skin to skin, oxytocin, initiate, it's not perfect, initiate blood loss monitoring, and delay cord clamping, particularly in preterm births. So to improve care in labor and in the third stage of labor, please try and remember these two mnemonics. Cope in labor, companions, oral fluids, pain relief, eliminate supine position. bond in the third stage, baby skin-to-skin oxytocin, initiate blood loss monitoring, delay cord clamping. And so just to show you how we do the bond thing, this is a birth in the steep lateral position. You see how easy that is. Once the baby's out, of course, the mother can then move to a recumbent position. B, baby skin-to-skin, O, oxytocin, initiate blood loss monitoring, and then delay cord clamping for at least 1 or 2 minutes, and then keep that tray in place until all the bleeding has stopped. And only once all the bleeding has stopped and we're satisfied, we can rub up the uterus and then remove the tray. Just a week ago, we did simulation training at Hanover Park Midwife Obstetric Unit, just with a model. So
I'll sort it out. Thank you.
Initiate blood loss. Delay cord clamping.
And it's been shown that this kind of simulation training is very important, because the more we do these procedures and we do them together and we use these mnemonics, it becomes it gets into our genetics, and it becomes easier for us to use these ways of doing things in the real life situation. I want to just talk very briefly about refractory postpartum hemorrhage, because there's such important new evidence. But I want to emphasize that our official guidelines in South Africa are still, this is when emotive fails. We've done everything. The uterus is empty. We've delivered the placenta. Our patient is still bleeding. So our current standard is still balloon tamponade, but we do have 2 randomized trials, in fact, showing that balloon tamponade with a condom is harmful. It does more harm than good. So we need to start thinking about alternatives, and the most important is suction tamponade. And already in the US, the routine for refractory postpartum is suction tamponade with a Jada device. Costs $1,200 per device. That's about something like 24,000 Rand per device. So for many years now, we've been using a simple suction tube, such as the Levine stomach tube. It only costs 5 or 6 Rand, or the Wishart intercostal drain, to do suction tamponade. These are our colleagues that we worked with in Colombia, doing suction tamponade. So it's a very cheap plastic tube. This is a blind insertion. We do also use an insertion with a speculum and with a swab holder to feed the tube into the uterus. It must be fed right up to the top of the uterus. You can see here on the scan the tube going right to the top of the uterus, and then we apply suction. And then once bleeding has stopped, or we think bleeding has stopped, we disconnect the suction, wait, rub up the uterus, check there's no more bleeding, and once there's no more bleeding, we simply remove the tube. There's another very simple method I think it's useful for us to know about, because it doesn't take any special equipment, and that is transvaginal clamping of the uterine arteries. We've known about it for many years. It's very simple, but very seldom used. So with a speculum, we visualize the cervix, hold onto the cervix with straight swab holders or sponge holders at 12 and 6 o'clock. Then move the retractor to the mother's left side, pull the vagina away, move the cervix to the right side, and then place a curved sponge holder high up in the vaginal vault, taking in the transverse cervical ligament and onto the lower uterine segment, exactly where you would be tying the uterine arteries if you were doing a laparotomy. And do the same thing on the right side, on the woman's right side, to clamp her right uterine artery, and then remove the swab holders and carry on with examining for a cause of bleeding. There was a recent randomized trial in South India where women with refractory postpartum hemorrhage were randomly allocated to a condom balloon or transvaginal uterine clamping or suction tamponade with a simple tube. In India, they actually use a stainless steel simple tube. And the failure of the instrument, in other words, the need to use a second instrument, was about 31% with a balloon, 6% with the clamps, and also about 6% with suction tamponade. And the need, the time to hemostasis was almost 10 minutes with the balloon and about 6 minutes with the clamping and with the suction tamponade. Blood loss more than 1,000 mils was around 50%, both for balloon and clamping, around 25% with suction tamponade, which was not statistically significant in the numbers studied. Now, we've recently published a similar randomized trial, but here comparing just the simple suction tamponade using the Levine tube with balloon tamponade, mainly either in the Alavi or the Bakri balloon. And this was in 10 hospitals in South Africa and 1 in Colombia. And our main outcome was blood loss more than 1,000 mils or laparotomy or death, was 30% with the suction tube and 52% with balloon tamponade. This was not quite significant in the intention to treat, but was significant in the per protocol analysis. But what was important is that severe pain during the procedure was much less frequent, 39% with suction and 84% with the balloon. And that's not surprising because the balloon is putting pressure on the inside of the uterus, and we know that that causes pain, whereas suction is simply collapsing down the uterus on the suction tube. Now, if we put together the data from the Indian study and the Colombian and the South African arms of our study, we see that this outcome of severe PPH, more than 1,000 mils, or laparotomy or death, was actually very similar in all of those studies. And when you put those all together by meta-analysis, you get a reduction of more than 40% in severe PPH or laparotomy or death, which is statistically significant. So I think this is the first reasonably strong evidence we have from randomized trials that suction tamponade may in the future be the way to go. Again, it's not yet official policy in South Africa, but it's something we should know about. So how do we implement evidence-based third stage care? Again, in Botswana, we've used the same approach. We have used a formal quality improvement project. We called it the ARREST PPH project. ARREST stands for Rapid Response, Emotive, and Suction Tamponade for Postpartum Hemorrhage. We have these posters up in our labor ward to remind everyone about third stage care, bond, baby skin to skin, oxytocin, blood loss monitoring, delay cord clamping, reminding them about monitoring, reminding ourselves about the Emotive project, reminding ourselves about ways of treating refractory postpartum hemorrhage, and emphasizing teamwork and speed. The thing about postpartum hemorrhage is that blood loss is very rapid, and every minute that you lose pushes you close to the point where you've had massive blood loss, you develop a coagulopathy, and you get into an unretrievable situation. So we have to diagnose early, treat rapidly, and not stop our treatment until we've stopped the bleeding. I'll perhaps just spend 5 minutes mentioning some other important life-saving techniques that we can all do wherever we are without equipment. We know that shoulder dystocia can be a fatal condition for the baby, and sometimes all our standard methods fail. So we all need to know about posterior axilla sling traction. the most useful thing is we must use a plastic catheter, not a rubber catheter that can do a lot of trauma. It must be a smooth plastic catheter like those suction tubes we should have in all our labor wards. Hold a loop of that in 2 fingers of the right hand, feed them under the axilla of the baby, use 1 finger of the left hand to pick up that loop, pull it through. Once you've got that sling in place, you can use it to rotate the baby. So this was a very, very difficult case where we had tried absolutely everything, including McRoberts, all the maneuvers. We couldn't deliver the baby. We again called for the suction tube, which should always be available in the labor ward, and then a loop of that suction tube is passed. This is the difficult part. Push it down, feel for the shoulder, push it under the shoulder, use a finger of the other hand to pick up the loop, pull that through, clamp your catheter. Once you've done that, you're in control. So you pull the posterior shoulder in the direction of the baby's back and push the anterior shoulder the other way. And you can really pull as hard as you like. You'll never do damage to the baby. And eventually, as you can see how tight this is, but as you pull that posterior shoulder around, it will always eventually pop out under the symphysis. And you can use that arm to rotate the other way. The other shoulder will pop out and the baby can be delivered. And this baby, although it was very, very difficult, was in absolutely good condition after the birth. How to improve our overall obstetric outcomes? Perhaps this will be the last thing that I mention. If we really want to improve maternal and perinatal mortality in South Africa, the one thing that will make the biggest impact is improving the way that we enable or empower young women and women of childbearing age to avoid unintended pregnancy. We know in our hospitals up to 67% of babies born, even after all of those terminations of pregnancy, are unintended pregnancies. And the vast majority of our maternal deaths are in mothers with unintended pregnancies. So unintended pregnancy is an unimaginable disaster for the mother, for the family, for the child, and for society. And we have to take this seriously. I think none of us are doing all that we can to empower women to avoid unintended pregnancies. And one of the important ways we can do this is with postpartum long-acting contraception, particularly the copper IUD. It can be inserted immediately after delivery. Within 48 hours, we have a window. If we miss the 48-hour window, we need to wait for 4 weeks. We must counsel our patients antenatally so that when they come in labor, we know what to do. I'll just quickly run through this. There are videos that I'll refer to in a minute. Post-placental can either be immediately by hand, but usually we do what we call postpartum. Ideally, we do it in the labor ward. We need just these simple instruments. The patient needs to be at the end of the bed, either in lithotomy or just holding up her knees or with her feet on the bed like this. In a sterile way, remove the IUD from the packet with ideally Kelly's forceps. We don't usually have them, so we just use a swab holder. If we're using the Nova T, we should cut the strings at about 11 centimeters. Then we clean the vagina, expose the cervix, very gently clean the vagina. We insert the copper T into the cervix. And then most importantly, we need to remove the speculum and change the angle and aim upwards towards the umbilicus. If we have, once the IUD is at the fundus, we can actually feel it abdominally with our hand. You can feel it right there under the skin. We then open the forceps, move it to the side, and remove it in the open position. I'm going to leave that there. In fact, let me just quickly show you IUD at cesarean section, then I'll stop. So at cesarean section, the most important part of suturing is suturing the angles. We take a good bite of myometrium medial to the angle, then pull it into view, and a lateral suture. So we have a very strong figure of 8, controlling any bleeders at that angle. Tie that tightly. We do have a full video at a site I'll show you on this, but I just want to show you the IUD insertion. We do the other angle the same way. A good bite of myometrium, but missing the endometrium, medial to the angle, and then use that to pull the other angle into view and put your lateral suture lateral to the angle. Tie that suture firmly. And then once you've done the angles, you can insert the IUD. We usually use the straw, but we remove that little blue collar and we remove the plunger, and we have the IUD just open like that, not tucked into the straw, and just feed it up with the straw to the fundus of the uterus. Then you need to just bend the bottom of the straw so you can get it into the lower segment, straighten it out and pass it through the cervix. You can see it there, and then continue the closure, and after the Caesar, withdraw the straw. And that's just to show our interrupted suture method, which we'll go into another time. So I'm going to leave it at that. I'm going to come back to, we had a lot to talk about where patients are born, but we're going to go right to the end. And just mention these training resources. Many of our videos are either on the WHO Reproductive Library, but I think most of them are on YouTube on what's called the Obstetric Skills Library. You can just type Obstetric Skills Library, and we also have weekly clinical case discussions on Wednesdays from 5 to 6 for our registrars and MOs with an interest in obstetrics. Please, if you have a problem, if you want advice, don't hesitate to contact me on my email or my WhatsApp, which are shown there. And I hope there's going to be time for questions, but thank you everyone for attending this, lecture. Thank you.
Oh, thank you very, very much, Prof. That was very inspiring. And I think I always have this feeling that like just this one little hour can save actually so many lives if we start implementing it, and especially having that best practice experience of really making a change. It takes hard work, but if one puts the work in, it's amazing to have evidence that it actually makes a difference. Prof, there is one question in the chat here. People, please do start. There's a couple of questions. The first question there is, would you suggest prepping or training the birth companion along with the healthcare education at the routine antenatal care? So I think it's also quite a good concept of how much do we involve a companion during antenatal as well, rather than just waiting to delivery.
Yeah, obviously that is ideal. I don't think it's something we're going to achieve. And interestingly, I'm amazed at how good companions are without training. I'm sure it would be better with training. But, you know, I often get this concern, you know, the companion's going to get into the way, they're going to faint with all the blood, you know, they're going to cause a problem, they're going to interfere. Of course, these things can happen. It's very, very, very rare. I don't know how many hundreds of companions I've seen in our labor wards. Often people say, no, the partners, it's not culturally appropriate for the partner to be there. Of course, if a particular woman feels it's not culturally appropriate, she won't have her partner there. She'll perhaps have her mother. But I've been amazed. And, you know, in Botswana, in the study, eventually 1 out of 3 companions were the patient's partners, and it was incredible how those partners were supportive and helpful and helped their partners. So to answer, ideally, yes, we should train them, but if you want to do rapid training on the spot, when the partner comes in, just say 3 things. It's what we said to our companions: comfort, reassurance, and praise, like CRP, okay? CRP stands for many things in medicine, but the important thing is just say to the partner, to the companion, stay with the woman in labor, touch her, rub her back, help her, give her fluid to drink, but comfort her, reassure her, and praise her. If you do those things, you'll make a difference. Thank you.
Thank you very much. People might have noticed that there's a poll that's popped up there. The HPCSA has requirements for us to have some sort of evaluation and proof that you were in the meeting. So please fill in the poll. If your device has not allowed you to see the poll, then please put your name and your MP number in the chat. But with the poll, we'll be able to pick up all the people that was present. So the next question is just, as part of PPH management, is there a role for anti-shock garment? Is there a reason why the balloon catheter is harmful during PPH management?
Okay, thank you. Yes, good evidence that the anti-shock garment is useful, particularly during transfer. And we do have it certainly in the Eastern Cape, hopefully in most of our hospitals. So it is something to know about and be able to apply when you transfer your patient. Then, sorry, anti-shock garment, the other one was?
Sorry, the balloon, it is
Oh,
a
yes,
reason
yes. Why should
harmful.
balloon tamponade? Okay, that's very interesting. It was particularly the condom balloon that was harmful, and it really was. You know, in both the studies, one was a study in Benin and Mali. It was an individually well done randomized trials. The woman with the condom did much better, much worse than women with no balloon. It may have been that, you know, using the balloon delayed other treatment. That's what people feel. But it also may be that the balloon actually prevents the uterus contracting down, because we all know that the mechanism for hemostasis is when the uterus contracts down, the muscles, you know, because remember the placental bed has got massive non-contractile arteries supplying blood to the placenta. Those arteries themselves don't contract. What closes those arteries and veins is the meshwork of myometrial fibers. As the uterus contracts down, those close off the bleeders. And so a balloon may prevent that contracting down and so make matters worse. In this respect, the Alavi balloon is probably better than other balloons, because the Alavi balloon doesn't have a fixed volume in it. You keep it open. So it doesn't prevent the uterus contracting. As the uterus contracts, the fluid is expelled out of the Alavi balloon. So it's a much better design than the fixed volume balloons. Thanks.
Thank you very much, Prof. Very practical. I see there's no other questions in the chat. Is there anybody who would like to put a hand up? Or if you are struggling with all buttons, you can also just unmute and ask. Just checking if there's any other questions. And please remember to fill in the poll or put your name and MP number or SANAC number in the chat. So Prof, I think what's also helpful is those links that you've mentioned. So for those of you that is part of RUDASA, we will definitely be sending out tomorrow the maternal sort of our resource pack, and on that there will be the links both to the WHO reproductive library as well as Prof Hofmeyr's YouTube channel, and that's sort of useful to go and find, you know, sort of become familiar with all these different little tips in terms of how to make delivery safer.
Madeleine, I know we're on time, but
Yes.
if there I really wanted to have questions, but if there are no more questions, perhaps I can just quickly mention a little bit about the place of birth, because I think this is another important issue. Our policy in South Africa is that low-risk women should deliver at community health centers. Now, this is obviously important to have facilities in the community for women who can't get to the hospital to be able to go to a local community health center. But it's not ideal. I'm sorry to say this. I wish it was. It's not ideal. because we know that of low-risk labors, at least 1 in 3 will have a serious complication, will have to be put into an ambulance, which often isn't there, and transferred to the hospital in labor, sometimes with a cord prolapse or a shoulder dystocia or a serious postpartum hemorrhage. So I know this may sound like, it may sound sort of heretical, but I believe we should not put obstacles in the way of women who prefer to come to the hospital to give birth, give birth. And one thing we should never, ever, ever, ever do is if a woman is at your hospital in labor, never send her to the clinic, because the worst thing for a woman is to be at the hospital, be sent to a clinic, to have a cord prolapse, and be sent back to the hospital with a dead baby. Never send a woman from the hospital to the clinic. So what do we have to do in our hospitals? Because we also know that hospital care isn't ideal. What is ideal is low-tech midwifery care. And I believe we can all, in our hospitals, make some way, or should I say we need to try to make it possible in our hospitals that for women who want to deliver in the hospital to have low-tech midwife-run care, ideally, I know it's not always possible, ideally in a separate on-site midwife birth unit. When we did this at Frere Hospital, it revolutionized our care. We looked at our births for 12 months before we had an on-site midwife unit, 12 months after. Before we had 6,500 deliveries in our labor ward, it was chaos. After opening the unit, we had 5,500 deliveries. It made all the difference. But overall, 7,500 women actually delivered in the hospital, because a lot of them were delivering in the midwife unit, and we didn't have to send anyone away. If they came in our front door, we just sent them to the midwife unit. And comparing those 2 years, maternal mortality and perinatal mortality was much lower after we opened the midwife unit. So I know not all hospitals can have a separate midwife unit, but what I say, try and make a provision in your hospital, somehow within your labor order, if you have a space, that low-risk patients who arrive at the hospital are not sent away, are welcomed and given low-risk care. The doctors must not see them. Doctors create problems. They must be looked after by the midwives only unless there's a problem. Okay, thanks. I just wanted to add in that bit.
Very inspiring. Lots of food for thought. And I really want to motivate you to be a change champion in your facility. Quite often we're in facilities and we sort of just go along with this is the way we've always done things. And it's very helpful to actually have clear evidence that making changes will save lives, and be willing to speak up and perhaps bring this kind of presentation, for example, to one of your CPD meetings or one of your morning meetings, and really discuss whether you can implement some of these simple methods to save lives. So a huge thank you again, Prof Hofmeyr, for coming to speak to us tonight. The webinar, obviously this video will also be making available and will be on the Redasa YouTube site. And then next week, we're having our week on emergency medicine, and we're actually going to have a talk by Dr. Day on angioedema, and looking forward to a topic that's we're starting to pick up some topics that has not yet been covered in the past, and does not always get enough airtime. So thank you very much, everybody. Have a lovely evening. It's time to get back to your families, and we will see you next week.